Welcome one and all to Equilogues 2017. Equilogues 2017 is a series of webinars organized by Achutha Menon Center for Health Science Studies, Sri Chittur Tirunal Institute of Medical Science and Technology. As all of you know, this is the fourth webinar in our series of webinars. Closing the Gap Health Equity Research Initiative India is a project run by Achutha Menon Center for Health Science Studies, funded by IDRC Canada, works to contribute to strengthening the evidence base of health equity research in India. The topic of today's seminar, Searching Equity in Access to Healthcare. We have with us as our speaker for the day, Professor Helene Schneider, Chair at the University of Western Cape, South Africa, and who is a visiting lecturer at Achutha Menon Center for Health Science. We also have with us Ms.Sulakshana Nandi, who is a state convener of Public Health Research Network Chhattisgarh and a PhD candidate affiliated to University of Western Cape. Without much delay, let's start off with today's presentation. Over to you, Professor Schneider.
Thank you very much, Dr. Malu. So I'm from the University of the Western Cape, as she said, in South Africa, and a few years ago was a co-PI on a research program that was examining specifically this question of equity in access to healthcare context. So I'm going to be talking a little bit about some of the core ideas that we used in that program, but Ms.Sulakshana Nandi, who has a long-standing collaboration with the University of the Western Cape, has taken forward the idea and is doing a PhD using some of the REACH framework and ideas, specifically focusing on equity and access in the Indian context in Chhattisgarh. So she'll be telling you a little bit about how she's applied ideas and concepts in her research. What I'll be doing in my presentation is firstly addressing the question of why look at equity in access, look at some definitions of the key terms, equity, access, and the two together, equitable access, consider a framework and some constructs in researching equity and access, and then we'll hand over to Sulakshana, who'll talk about equity and access in the under RSBY and SBY in Chhattisgarh state, and hopefully you'll be then gathering some questions, ideas, experiences that we can have a conversation about in the Q&A session later. So first of all, why study equity in access? Well, inequities in access are unfortunately very common in health systems. In India, in South Africa, in high-income countries, it's a very common situation that the availability, affordability, acceptability of services are unequally, inequitably distributed in health systems. And in fact, it's so common that we, in 1971, Tudor Hart, a British researcher, coined the inverse care law, referring to the fact that the availability, access to care is inversely proportional to the need for that care. And that is commonly referred to in the literature on equity in access, is the inverse care law. Equity in access is also central to achieving universal health coverage, which is the big international platform around health systems. And in fact, if you look at any of the writings on universal health coverage coming from the WHO or other international agencies, one of the first objectives of universal health coverage is equity of access in health systems. So what is it? What is equity of access and how can we assess it? Let's clarify what we mean by these different terms, starting with the word equity. So equity refers to differences in health that are systematic, socially produced, and therefore modifiable and unfair. The term equity is differentiated from inequality. Equality would denote any differences, some of them which are not socially produced. So health status that is, for example, a product of genetic factors may not be socially produced and unfair. And that would differentiate the word inequality from inequity. Consider equity in two dimensions, horizontal and vertical equity. Horizontal equity would be all equal needs treated equally. Unequal treatment with unequal need would therefore be vertical equity. And the expectation would be, if need is unequal, that the distribution of resources would therefore also be unequally distributed in those with greater need. And that's the concept of vertical equity. Let's look at the definition now of access. So there are many ways in which people have defined access. There are a lot of different terms often deployed to describe access, but all generally converging on a few core ideas. So this is the definition that we used in the REACH project. Access, as the degree of fit between users, populations, and providers, the health system, in the dimensions of availability, affordability, and acceptability, sometimes referred to as cultural access. So there are a number of ideas there. The degree of fit is a notion of it's a notion of fit between players, providers, demand and supply, that implies a dynamic. It's not a universal one-size-fits-all. So availability, which is the, for example, the physical services, it includes the rights package or scope of services, the right quality of those services, right place, delivered in the right way. If considered in a dynamic of fit, would imply that some users and populations may have different needs for availability than others. So if you're physically disabled, a health facility within 5 kilometers of walking distance is no good to you. Maybe fine for able-bodied young people. So that's the notion of dynamic, that it has to always consider the needs and the access in relation to the needs. Affordability is the relationship between the cost of using health services and the ability to pay for those services. So on the supply side, what prices, what fees are set for services, and on the demand side, the degree of affordability. So some people may be able to pay fees, other people may not be able to pay fees at all. Affordability would include also indirect costs of using services, transport, lost time, opportunity costs. So affordability would take into account all of those different dimensions. And finally, acceptability would be the extent to which the way services are provided, providers, the norms and cultures of those service providers and service and health facilities match their expectations, norms and values of the users of services. So that really is the approach to and definition of access we've used in our research. Those two concepts together, access and equity. In access, it can be defined as the just distribution of healthcare according to need. So remember, in the original definition, it was the distribution of health outcomes. Here we're interested in the distribution of healthcare and its relationship to need. And following the notions previously described, those with greater needs should have greater access to care, vertical equity, while those with equal need should have equal access, horizontal equity. The concept of access is often conflated wrongly of use. So, for example, people may use as a proxy of access coverage of services, whether it's immunization or antenatal or delivery services, may use that use of those services, the uptake of services, as a proxy for examining access. But in reality, access is the determinants of that use and need to be examined in and of themselves as factors, as some would frame the opportunity to use those services, even if that use is not realized. And that's what equity in access seeks to examine. Another aspect of equity in access or of access is that traditionally people have looked at differences in availability or affordability of services by socioeconomic status and often ignore other equity factors such as gender, caste, rural status, citizenship. So an approach to equitable access needs to also think holistically about all of those different dimensions. So what I'm going to show you now is how we brought all of that framework in the Researching Equity in Access project in South Africa. Quite simply, we put together our 3 dimensions of access there on the left: availability, affordability, of acceptability, and call that access. We looked at the relationship between those access factors and use of services, and we were then hypothesized that would lead then to differential outcomes. We were interested in a number of equity factors, individual level, so socioeconomic status, which we measured through the use of an asset index, using techniques such as principal component analysis. We were also interested in gender differences, in race as a key element stratifier of access in South Africa. We have a lot of migrant populations in South Africa. So we looked at those individual level determinants of all of those access variables. We were also interested in group level determinants, urban status, the place. We studied different sites across South Africa, and facilities. So we were interested in looking at facility level variation in, for example, quality. What's not represented here is the fact that we looked at equity in access, not at all dimensions of the health system, but we focused on particular traces of these conditions. In our instance, it was maternal deliveries. It represents a large episodic event, requires coordination, for example, between primary healthcare and hospital services, and it requires access to emergency obstetric care as well. We looked at that as one aspect. We looked at antiretroviral access, which is a primary healthcare-based service that requires long-term relationships between users and the health system. We looked at that as one variable, and then also as tuberculosis. That's in a similar category, but an older service that historically has been neglected. So those were our traces that we used. Here is another framework for looking at equity in access, a slightly more sophisticated, complex diagram in the context of thinking about universal health coverage. So what you can see there on the left-hand side are the supply side of the health system, the availability, those blocks in the middle, to a health system on the left. I don't know if I can have an arrow here. I don't know if you can see that, but a set of health system inputs leading to availability, accessibility, and acceptability. And accessibility here is taken as affordability. That leads to utilization and to the notion of effective coverage. So it is when you've got coverage of services that are effective, it's not just having had an immunization, it's actually an effective immunization that protects you, for example. And that would lead to then the notion of universal health coverage with equity, taking into account differential health needs. And then the equity elements that influence that vulnerability, the equity dimensions referred to earlier, influenced by social policy on one side and health policy on the other, as a composite framework for thinking about equity, and each of those representing a degree of fallout with unmet need levels. So how did we operationalize those concepts of equity in our project? It was a very multi-method project that used qualitative, quantitative interviews. We worked with household information where we had it, indicators of need from demographic and health surveillance sites. And we also did a lot of interviews with users of health systems and people who didn't use the health system. And really to try and those three dimensions of access, we had to think of indicators and variables. So indicators, for example, of availability would be travel time to facility, mode of travel, waiting times, drug supplies in the facilities as an indicator of quality. Affordability, we looked at household income, the borrowing and selling of assets at times of use of services, those as indicators of ability to pay. And then the costs of use of services, so the indirect costs as well as the direct costs incurred in utilizing services. Acceptability, the extent to which users perceive to be respected by providers, the extent of privacy. And then we try to get at this complex construct of trust, not in quantitative ways, but more in qualitative process of interviews between players. So that is a brief introduction to how we approached and some core ideas in equity and access. And I'm now going to hand over to Sulakshana a little bit about how she's worked with these ideas in her research. Over to you, Sulakshana.
Yeah. Thank you, Professor Schneider. Dr. Malu, if we can have the slides on.
Yes. Sulakshana, your slides are visible. Your slides, so you can just.
Okay, it's not visible to me somehow. So.
You can go to your slideshow. You can just go to your slideshow and keep changing slides.
Yeah. So I'm currently I'm a PhD candidate at the University of the Western Cape. I've been using the access framework that an adapted version of the access framework that Professor Schneider just shared in looking at equity access utilization in the state-funded universal health insurance scheme in Chhattisgarh state. In Chhattisgarh, the RSBY, as you all know, the Rashtriya Swasthya Bima Yojana has been universalized. So there are two schemes, the Mukhyamantri Swasthya Bima Yojana that's meant for the above poverty line, the APL, and the RSBY, which is meant for the BPL. So as part of my PhD, I have used the framework in undertaking 3 studies which examine the specific access dimensions and also the relationships. The study 1 examines the relationship between availability, utilization, and geographical equity through the use of the district level program data of the insurance scheme. Basically, so I'm looking at availability under this study. Study 2 basically it examines the financial protection and the utilization under the scheme, and tries to understand the dimension of affordability under the RSBY and the MSBY in detail. And study 3 uses it's a qualitative study which uses a case study design to look at instances where people have used, especially individuals from vulnerable groups, for instance, from tribal communities, from the urban poor, who have utilized hospitalization and utilized the insurance scheme in the hospitalization, and how they were able to negotiate or navigate access under the insurance scheme. So the framework which has been adapted from the REACH project, I'll just take you through it briefly. So again, like Professor Schneider has shared, so on the left side you have the three dimensions of affordability, acceptability, and availability. So in affordability, uh, in terms of indicators, I've been looking at out-of-pocket expenditure, the catastrophic expenditure that people have had to incur, if any, in finally utilizing the services in the private and the public sectors. Availability has been the indicators that I've looked at has been enrollment levels, whether the levels of insurance coverage and inequities within that. So whether there has been sort of equitable enrollment coverage under the insurance scheme across the urban and the rural areas, across various caste groups, across gender, across economic status, and then also look at the distribution of the facilities that have been empaneled under the insurance scheme, because that basically would also um, uh, cater to the availability dimension, and I will discuss that further in the next two slides. The third aspect of acceptability, which I've further clarified and have also sort of added the issue of agency, because it's not all, I mean, it is in part the perception or the responsiveness of the health system or this particular uh, insurance scheme to the people, but also in terms of how empowered people feel in order to utilize this particular insurance scheme, and whether there are systems of grievance redressal, and how and what are the barriers that people face in terms of I mean, when they go to a hospital and want to use this insurance scheme for treatment. So that is what I'll be looking at. I'm looking at in acceptability and agency, and it's and as the model suggests that all three would finally lead to access and utilization of hospitalization and the insurance scheme within a larger context of the way the health system is in those areas, and also on the larger context of the existing inequalities that may result in different experiences for different groups, and the dimension of inequity or equity in the utilization and in the access, and then finally the utilization. It's important to state, that it's not possible to study these dimensions inside. I mean, they are not. Uh, uh, they cannot be studied in isolation, and it's very important to understand that they affect each other. The affordability, acceptability, availability affect each other, and there is, for instance, I'll just share one particular example from the first study that I've done, in which I have distributed the districts using a vulnerability index in terms of vulnerability groups. So if you see that the highest vulnerability groups are the areas which are darker which have a darker color, which geographically is at the extreme of the periphery of the state in the north and the south, which also happen to be mainly tribal dominated districts, and the lowest vulnerability districts are the ones which are nearest to the state capital, which is shown by the black dot. And when we distribute the health facilities, the available health facilities in these particular districts under the RSBY, MSBY, you can see that in terms of facility availability, there is no availability in the central area, and and the relationship basically between enrollment, the availability in terms of facilities, and enrollment is very important. In Chhattisgarh, we found that enrollment is quite equitable because it's a universal scheme, and there has been some emphasis initially on covering a lot of the tribal and vulnerable, some of the tribal groups and the rural areas. So, uh, so when we analyze enrollment, it comes to be overall equitable. But when we analyze the claims data, depending on the nature of availability of facilities in the various groups, we find that the areas which are the most vulnerable have actually the least number of facilities. So this is so therefore it's very important to sort of compare and see the relationships and the interactions between the three dimensions, rather than looking at it in isolation. Yeah, thank you.
So that, with that introduction, maybe you have some questions about how one approaches researching equity and access, and we encourage you to think about them so we can talk more in the Q&A session. Thanks, everyone.
Thank you, Professor Schneider, for that wonderful talk, and thank you, Sulakshana, for your patience and your inputs. We are very happy that we've been able to successfully conclude this session. I know that we haven't had time for a question and answer session, so I'm sure all of you would be interested in asking questions. But I want to convey to you that on 22nd we will have a detailed. Okay, 21st we will have a detailed question and answer session, a live Q&A session. So where all of you and all the participants who had registered for our Equilogues would be able to interact with Professor Ms.Sulakshana Nandi personally. Hope you've had an enriching learning experience. Thank you.